Hello, and welcome to an evidence-based approach to assessing cirrhosis in the jaundiced patient, a video produced in conjunction with the UC Davis School of Medicine. In this video, we'll provide a quick overview of the evidence-based physical exam, discuss an evidence-based approach to physical diagnosis and assessment of cirrhosis of the liver and of a patient presenting with jaundice, and finally provide a video of a UC Davis Master Clinical Educator demonstrating high-yield physical exam maneuvers that every UC Davis grad should know, and the evidence behind them. Hand washing before and after each physical exam has been well studied and shown to reduce morbidity and mortality in the hospital and the clinical setting. We all know the four basic tenets of the abdominal exam: inspection, auscultation, percussion, and palpation. And while these provide the foundation for our abdominal exam, this video will discuss a different approach. An evidence-based approach to the physical exam begins with a diagnostic question. For example, does this person have chronic anemia? To answer the question, you first estimate a pretest probability, which is essentially your best guess as to how likely you think this patient is to have the pathology in question, based on aspects of their history, presenting symptoms, etc. It's generally expressed as a percentage. Using this as your starting point, you choose an evidence-based physical exam maneuver, which, depending on whether the test is positive or negative, will feed back on your original hypothesis, giving you a new post-test probability, as demonstrated in this figure. For example, if you don't think that your patient is anemic, giving them a pretest probability of 20%, but then you discover conjunctival pallor on exam, that really changes your thinking, giving you a much higher post-test probability. How much a given physical exam maneuver changes your pretest probability depends on the sensitivity and specificity of the test, which in this case is expressed as a function called the likelihood ratio. You can see in the figure how a positive or negative likelihood ratio can affect your pretest probability either a great deal, for example if you have a positive likelihood ratio of 10 or more, or barely at all, for example a likelihood ratio close to 1. Let's see how we'll use this when assessing a patient who we think may have cirrhosis. So when we're assessing a patient that we suspect may have cirrhosis, we start by estimating our pretest probability, which is our best guess as to whether or not we think the patient has cirrhosis, and how sure we are of that guess, expressed as a percentage. And this is based on aspects of the patient's history, such as their age, their past medical history, their substance use history, etc. From here, we select evidence-based physical exam maneuvers that will help to modify our original guess. Now, many of the items listed on this slide may look familiar to you as the stigmata of chronic liver disease. But in the many studies that have been done assessing their efficacy and their inter-observer reliability, it turns out that they have not all been shown to be equally predictive of cirrhosis. Highlighted in yellow are some of the exam maneuvers that research shows are most high yield in either making cirrhosis more or less likely in your patient. First, we'll discuss the finding of spider angiomas, which has a positive likelihood ratio of 4.5 and a negative likelihood ratio of 0.5. Here we see a picture of a spider angioma, called such because it resembles a spider in its radiating appearance. These are dilated capillaries thought to be due to hyperestrogenism associated with chronic liver disease. You can often either find them on the body wall or on the head. Note that they have a characteristic blanching appearance, meaning that when you push down and let go, they fill with blood from the center radiating outwards. Next, let's talk about another physical exam maneuver that's found to be predictive of cirrhosis, palmar erythema, which has a positive likelihood ratio of 4.3 and a negative likelihood ratio of 0.6. It may help to actually compare your own palm to the patient's palm, as this can oftentimes be a subtle physical examination finding. Another high-yield physical exam maneuver that you can perform just by inspection is looking for the presence of dilated abdominal wall veins, which has a positive likelihood ratio of 9.5. Now this can look like the traditional caput medusae that comes from the recanalization of the umbilical veins, but it can also be more subtle in the presence of just dilated abdominal wall vasculature as seen here in this picture. Another very high-yield finding in the diagnosis of cirrhosis is the presence of encephalopathy, which has a positive likelihood ratio of 8.8. Now, you can diagnose this by the presence of altered mental status and also by the presence of asterixis, or flapping tremor, as demonstrated here in this video clip. Let's take a moment to look at hepatomegaly and splenomegaly on the list. With a positive likelihood ratio of 2.3 and a negative likelihood ratio of 0.6, hepatomegaly is not necessarily sensitive or specific for cirrhosis, and this is because the liver can be either small in advanced cirrhosis or it can be enlarged in the early stages. That being said, it's important to learn how to do a good liver and spleen exam to assess for hepatomegaly and splenomegaly as part of the abdominal exam. Here to teach us more is Dr. Mark Henderson.
Now we're going to demonstrate how to examine for hepatomegaly, or an enlarged liver. There are two ways to do this. The first is palpation, the second is percussion. We'll demonstrate both. To palpate the liver, we begin in the lower abdomen, so we know the liver is located in the right upper quadrant, but we begin palpation in the right lower quadrant, certainly below the level of the umbilicus. So I usually use two hands, with my upper hand I'm going to be applying pressure, and with the lower or examining hand I'm going to be feeling for the liver. And I'm going to begin having the patient take deep breaths in and out. Great. Now let it out. As he expires or exhales, I'm going to press a little bit farther in. Again, take a deep breath. Good. And let it out. And I'm slowly inching up towards his right upper quadrant. Another deep breath. Yeah. And then one more time. There, I'm feeling a little bit of the edge when he take a deep breath again. I feel the edge of the liver hit my finger right there. Okay, relax. Now, that's palpation. The problem with palpation is the location of the inferior margin of the liver doesn't really tell you how big the liver is. So if the liver was massively enlarged, you might feel it in the right lower quadrant, or you might be able to feel it in the mid-epigastrium. But percussion is a much more reliable technique, so let's talk about that. So if you think about percussion, the liver typically sits around this, right around here. So the superior margin is up in the chest. So the right side of the chest, when you percuss, again, you're going to hear resonance. And we're going to percuss down inferiorly until we hit an area of dullness. Right there, so we just hit liver, dull, dull. Let's get a little bit less dull. Sometimes I'll put a little mark on the patient, at the top of the liver, a little dot, and then I'll just percuss the span. This is the span in the craniocaudal direction, right in the midclavicular line. So I'm going to percuss down. This is dull, dull. Starts to get hollow. So here I'm in the abdomen. So dull again. So right there is the inferior margin. So then the dots here, I would estimate they're 1, 2, 3, 4, 5 finger breaths. So that's 5 or 6 centimeters, so the span is 6 centimeters.
Next, Dr. Henderson demonstrates a technique for both palpating and percussing the spleen, using Castell's sign for percussion. He begins by demonstrating the location of the spleen, which is located underneath the rib cage on the left side, between the 9th and 11th rib space. So, in order to palpate, one thing you can have the patient do is either roll over into right lateral decubitus position or use your left non-palpating hand to pull up on the rib cage and bring the spleen towards you, while you use your other hand, in this case Dr. Henderson's right hand, to palpate.
I'm going to begin here in the left lower quadrant and have him begin to take deep breaths. Take a deep breath in, good. Good. And then I'm going to keep pressing. As he exhales, I'm going to try to get my hand under deeper and deeper into this left upper quadrant. Again, good, and then right here, again, I don't feel it, but this is where the spleen would come away and touch my hand with inspiration as the diaphragm brings it down towards my hand. So again, you need to start in the left. Here's the umbilicus, the left lower quadrant, deep breath. Make sure you start here, because if the spleen is massively enlarged, you'll be below it.
Next, Dr. Henderson demonstrates percussion of the spleen, which is a more sensitive way to identify splenomegaly. This again relies on the fact that with deep inspiration, the diaphragm pushes the spleen down further into the abdomen.
And what you'll do is draw a line in the anterior axillary line down here to the left costal margin, and then move up one intercostal space here and percuss. That's a resonant note. And then have the patient inspire. Remember, with inspiration, the diaphragm will move down and push the spleen forward and down. So if he has splenomegaly, an area of dullness will appear under my finger as he breathes in. So I'm going to begin percussion and have him start taking deep breaths. You can hear. See, I think it gets dull.
A 1993 systematic review in JAMA found Costell's sign to be the most sensitive way to identify splenomegaly, with a sensitivity of 82% and a specificity of 83%. That being said, you would still need to have a pretest probability of around 70% for this patient to have splenomegaly for a positive test to give you a positive predictive value of greater than 90%. Meaning that this test is only really going to be useful in patients where you have a reasonable suspicion that they may have splenomegaly. For example, if they have signs or symptoms of mono, advanced cirrhosis, or you're practicing in a country where malaria is endemic. Now you may have noticed that the presence of splenomegaly on exam wasn't all that predictive of cirrhosis in the many studies that have assessed it, with a positive likelihood ratio of 2.5 and a negative likelihood ratio of 0.8 from the pooled data. However, I did want to mention one study that did find in a series of 184 patients with known cirrhosis that splenomegaly in combination with moderate thrombocytopenia was predictive of clinically significant esophageal varices, with 34% of patients having both findings also having large esophageal varices documented on EGD. So it still can be a useful sign in determining whether or not your patient may be at risk for variceal bleeding if you're concerned about cirrhosis. Now let's use McGee's evidence-based physical diagnosis calculator to see how some of these physical exam findings will influence our pretest probability. First, we choose cirrhosis from the drop-down menu and choose a pretest probability based on our patient's past medical history and presenting symptoms, things that may influence the likelihood that he or she may have cirrhosis. Let's say we pick 30%. So first, let's look at the presence of spider angiomas and palmar erythema, which have pretty similar positive likelihood ratios of about 4.5. So we dial that up, and we look at what happens to our pretest probability. Remember, initially, we were 30% sure that our patient had cirrhosis. Well, if we see one of these tests is positive, if we see spider angiomas, for example, our pretest probability nearly doubles. Now our post-test probability is over 60%. This makes a big difference in the way we think about our patient, how likely it is that they have cirrhosis. Now, both of these findings also have similar negative likelihood ratios of around 0.5. So if they don't have spider angiomas or they don't have palmar erythema, well, then our pretest probability decreases a little bit to just under 20%. Now that's not much of a difference, and 0.5 is about the threshold for where our likelihood ratio is significant at all. Note that even with a relatively high pretest probability of 60%, a negative likelihood ratio of 0.5 only changes our post-test probability by a small amount. Next, let's consider the presence of dilated abdominal wall veins, which has a positive likelihood ratio of almost 10. Note what this does to our pretest probability. It takes it from 30% to around 80%, which really changes the way we think about our patient. Essentially, if you see dilated abdominal wall veins, we become much more concerned that this patient has cirrhosis, causing portal hypertension. Next, let's consider ascites, which has a positive likelihood ratio of around 6.6. This takes our pretest probability from 30% and bumps it up to a post-test probability of almost 75%. Again, that's almost double. So finding ascites on exam is going to really change the way we think about the probability that this patient may have cirrhosis. But let's consider its negative likelihood ratio, which is 0.8. Remember, 1 is not significant at all, so 0.8 is pretty close to that, and lo and behold, if we do not see ascites, our pretest probability goes from 30 to about 25, not significant at all. So let's talk about another distinction that physicians are going to often be required to make, and that is in the evaluation of a patient that we already know is jaundiced. And we need to figure out what the etiology of the jaundice is. Is it hepatocellular, obstructive, hemolytic? So again, we start by coming up with our pretest probability, which is our best guess as to what type of jaundice this patient has, based on the relative prevalence of each type of jaundice, and also, importantly, aspects of that patient's history. Do they start taking any new medications? Do they have any substance use history? What's their past medical history, etc.? And from there, we move on to using our evidence-based physical exam maneuvers to change our pretest probability, make it either more or less likely that in this case, our patient has hepatocellular injury as an etiology for their jaundice. And notice that we see a lot of the same physical exam findings that we saw in our evaluation of the cirrhotic patient, and that's because repeated hepatocellular injury and cirrhosis go hand in hand. But I want to point out one physical exam finding down at the bottom, a palpable gallbladder, so-called Courvoisier's sign, which has a positive likelihood ratio of 0.04, meaning that if you see a palpable gallbladder on exam, all of a sudden it makes it extremely less likely that this patient has hepatocellular injury as the etiology of their jaundice, much more likely that it is obstructive in nature. So we choose jaundice from the drop-down menu, and we note right away that the pretest probability is very narrow and very high, owing to the relative paucity of data on the subject, and also to the fact that most jaundice is due to a hepatocellular etiology, so the pretest probability is high. We then choose a physical exam maneuver, like the presence of spider angiomas, which has a positive likelihood ratio of 4.7. We see our pretest probability jump up to nearly 90% as a post-test probability, making this a pretty high yield finding. Next, pulmonary erythema with a positive likelihood ratio of over 9, bumping our post-test probability up to over 95%. And finally, dilated abdominal wall veins with a positive likelihood ratio of 17%, essentially cinching the diagnosis that our patient's jaundice is from hepatocellular injury. Conversely, imagine that our patient has a palpable gallbladder, so-called Courvoisier's sign, which has a positive likelihood ratio of 0.04. Look at what that does to our post-test probability. First, we were 65% sure that our jaundice was hepatocellular. Now we're less than 10% sure. And this is because a palpable gallbladder is so specific for obstructive jaundice. So to conclude, I'd just like to review 4 take-home pearls from this video. The first is that of all elements of the physical exam in assessing a patient with suspected cirrhosis, observation is probably the highest yield, and we learned some of those particularly validated exam findings, like spider angiomas, pulmonary erythema, or distended abdominal wall veins. Second, make sure to be familiar with the morphology of spider angiomas, including where on the body to find them and their characteristic blanching appearance. Third, learn how to properly use palpation and percussion to examine your patient for hepatomegaly and splenomegaly. Remember, when you palpate, start far beyond where you think the normal inferior margin of these organs are, so that you never miss a massively enlarged liver or spleen. Also, generally, palpation is not enough to diagnose a patient with hepatomegaly. If you think you palpate the liver edge below the costal margin, your next step is to percuss the liver span, which is a much more specific test for hepatomegaly. Finally, understand how critically important the idea of pretest probability is when you're interpreting your physical exam findings. For example, when you're using Castell's method to percuss for splenomegaly, a positive result would be interpreted much differently in a patient that had aspects of their history that were concerning for splenomegaly, a so-called high pretest probability. Then a positive test would be in somebody that has absolutely no risk factors, somebody who has a baseline very low pretest probability.